Hello, good morning, everyone. Again, this is Dr. Farooq from ER Skill Lab and Bangladesh's Bangladeshi Emergency Medicine community. Welcome again. Today we have Dr. Said. We met already Dr. Said, who is an endocrinologist, recently joined in Broomfield Hospital. Welcome, Dr. Said, this morning.
Thank you. Thank you, Farooq bhai. Thanks for having me
So
once again.
this is the second time we invited you because of we didn't cover a lot of emergencies last episode. I think mainly we covered DKA basically. So today we'll step down and we actually come out of the DKA today. We'll
Yeah.
discuss with other third emergency, for example, Addison's crisis, pheochromocytoma, pituitary apoplexy, those things. Let's see how much we can cover. Uh, Dr. Said, again, can you tell us? So we would like to start with Addisonian crisis.
Yes.
In emergency department, how they present and what are the presentation look like?
Okay. Thank you, Farooq bhai. Thank you once again for having me. Um, I think Addisonian crisis is the core endocrine emergency interlink. And let me start with a case scenario, with an ideal case scenario. Um, think about a young person, maybe in their 30s or 20s, and they come to ED, complain of they have been vomiting all night. And when you see them on front row, you see them quite hypotensive and uh, say a little confused. Um, you then immediately start thinking about all the differentials of a hemodynamic compromise. So you send an initial blood test and you see all the typical biochemistry, for example, low sodium, high potassium, and then you pick Addisonian crisis as one of your top differentials. So this is ideal. If someone with hypotension or hemodynamic instability in ED, and you are ruling out all the potential causes, and you start thinking about Addisonian crisis as well, you're doing the right thing. So that's how they present. Most often, people present with ED with hemodynamic compromise. So when an Addisonian crisis, be it a diagnosed case or be it a new presentation, more often than not, they will present with a trigger. So you will see other features that has triggered the crisis actually. That could be sepsis, that could be any other intercurrent medical issues, for example, a surgery, recent childbirth, all these things.
Can I ask you something, Said? No, this is a
Yeah,
it could be confusing presentation sometimes in ED point of view. Is someone coming hypotensive,
yeah,
vomiting, confused? Uh,
yeah,
let's say if someone didn't look into the sodium and potassium, what, how much,
yeah.
what are the other differentials people consider initially, may consider initially? Mhm.
Okay. So for the emergency physicians, anyone coming with hemodynamic instability, you actually you don't think about Addison's disease. You think about sepsis first, or you think about a cardiac cause.
Mm.
So I think when you see a hemodynamically compromised case, the first thing first, you rule out sepsis, possibility of sepsis. If
Mm.
you don't see there is no clinical suggestion of sepsis, and probably not cardiovascular compromise because of a cardiac cause, then you start thinking about um, Addison's disease. So when you do that, when you suspect Addison disease is a top differential, or if you ruled out a primary suspicion of sepsis or heart failure, you then treat for a suspected Addisonian crisis without waiting for bloods. So I'm
Right.
saying this because
Mm,
you may want to see the hyperkalemia as the myth of Addisonian crisis association, but many a times potassium can be normal, particularly if crisis is if adrenal insufficiency is resulting from a secondary or tertiary
mm,
cause, like a pituitary dysfunction or hypothalamic suppression. Although dipping into Addisonian crisis is less likely from a secondary or tertiary cause than a primary, but if we are talking about biochemical abnormalities, it's more associated with primary adrenal insufficiencies than not.
mm. So no, I agree with you because initially, as an undifferentiated patient, it can appear as sepsis, even though sepsis is could be
Yeah.
the trigger of Addisonian crisis. And some people who don't have
Yes.
history, you said vomiting and low blood pressure, confusion.
Yeah.
We think of sepsis and try to rule out sepsis and other cardiac causes. And I,
Yeah. And
Mhm.
the interesting bit is, I mean, it may not be a septic patient. It may be a Addisonian crisis triggered by a sepsis.
True.
And then you should, of course, treat sepsis first, but you should keep an eye out and an ear out to see if there is any suspicion. And at that point, clinical features like association of other autoimmune diseases. Say this patient has also autoimmune thyroiditis or type 1 diabetes,
Hmm.
or they have vitiligo, or they have a family history of autoimmune diseases.
Hmm.
And for example, patient profile, if you are looking at a 30-year-old woman who has been pretty fit and well until last night, and since last night suddenly become very compromised. So you think of an autoimmune association or Addisonian disease crisis as your stronger differential than sepsis alone,
Sure.
despite of some evidences of infection
Hmm.
from clinical point.
So I think the approach should be wide, covering sepsis, hypotension.
Yeah.
Obviously, in ED, we do initially the VVG, ECG, blood cultures, and everything, and probably
Yeah.
start the sepsis treatment, fluids, all this. So, and
Yeah.
then, yes, once you have the VVG, obviously, in all the patients in ED have VVG, and then I think there
Yeah.
is plus or minus, you do see, take a good history,
Yeah.
uh, young patient, no other big issues, but again, you suspect of autoimmune or it's in a crisis. All these things come much
Exactly.
clearer as we go. And tell us what's next. So initially, yeah, we started the patient come in ED point of view. So we send them
So,
ECG and everything. Um,
mhm.
and tell us about
So
mhm,
the trap in ED is waiting for blood tests to come back. Some may think, okay, can it be a Addisonian crisis? Let's do a random cortisol and see what it is. And you do a random cortisol and wait for that. That's the trap. So whenever the myth is, if you suspect Addisonian crisis, hydrocortisone is out. So don't wait for the blood test. Addisonian crisis is best treated on clinical suspicion. So high index of clinical suspicion. It's an ampoule of hydrocortisone and a liter of bag. That's the difference between life and death.
hmm,
So clinical suspicion, treat sepsis, treat whatever the intercurrent illness is. But if you are suspecting as an emergency physician, there could be possible association of Addisonian crisis. Start on crystalloid and, of course, start on IV hydrocortisone. The bolus is 200 milligram IV hydrocortisone,
mhm,
stat, and then you can either start them off on IV hydrocortisone, 200 milligram IV hydrocortisone, continuous infusion over 24 hours, or you can keep them on intermittent IV hydrocortisone 6 hourly. If you are now imagine if you are dealing with a peripheral vasculatory collapse,
Mm.
Addisonian crisis, sepsis, everyone will come. So you may have significant delay, not ideally, but you may have in some cases significant delay in getting IV access. You do not wait for that IV access even. You can straight away go with IM
I
because
am.
that's literally will save life. So IV or IM hydrocortisone, a bolus, and then a maintenance infusion of 200 milligram IV hydrocortisone over 24 hours is one strategy, or you can do intermittent infusion as well.
Mm.
If possible, if without causing any potential delay, you can get some blood samples. You should always get blood samples for all the organ function, including a random cortisol.
Mm.
And of course, use an easy one to see. You will also take blood cultures, ECG, and everything. Very important is to see whether patient is hypoglycemic or not, because that will change your fluid management. And
Yeah.
Addisonian crisis will very often present with hypoglycemia.
Mm. Okay. I think you're right. So we obviously we need to, as soon as we suspect, we need to jump
Yeah,
into treating with
yeah,
hydrocortisone,
yeah.
statin fluids, and while we're investigating further.
Yeah.
And I think I like the idea. So you give the bolus, and then you actually can give 24 infusion, 20 milligram over
Yeah.
24 hours.
And you have the freedom to kind of tweak it, and you are not intermittently bolusing them. So when you have more results coming in, then you have the freedom of tweaking the infusion if you are starting them on infusion. So I always prefer starting them on 200 milligram continuous infusion rather than bolusing intermittently. Plus, also there is a chance that subsequent doses may be missed as patient moves from ED and goes to acute medical area or in a medical ward, for example.
Thank you. So this patient, what happens? What happened? This is just a curiosity. What if
Yeah,
someone missed the diagnosis, did not give hydrocortisone? What can?
yeah. Okay, so if someone has got true deficiency of cortisol and in circulatory collapse, and you are treating with IV fluid but not giving IV hydrocortisone, you will not win the battle.
Mm.
You will not achieve target blood pressure. So you will be treating them sepsis. They will be refractory to treatment of sepsis. Or if you are treating heart failure, they will be refractory to it. So what you will do, you will probably call ITU um, for a vasopressor, but relentlessly, you will not be achieving that, and they will remain hypotensive for longer term,
Mm.
and they will slowly develop organ dysfunction, kidneys, liver,
Mm.
uh, and cardiovascular compromise. Finally, cerebral anoxia, and their CNS will be slowly depressed.
Mm.
So if you are imagine a NHS setting, this probably will be steroid probably will be given sooner or later because when you start vasopressor that doesn't respond, you will call ITU, they give vasopressor that doesn't respond, they take them to ITU, they probably have got their protocol and the patient will get some steroid or not.
I'm I'm just saying.
But if in a resource setting, they will simply die.
Yeah, I'm just saying because we have Bangladeshi audience, because in Bangladesh, let's say
Yes.
in resource limited area or somewhere in the
Yeah.
periphery, they might not think the
Mm.
differential or they might not start it.
Yeah.
So anyone, I would say anyone with refractory hypotension, refractory,
Yeah.
sepsis or hypotension that you cannot manage with fluids or anything else. So that also
Mm.
trigger that are you missing something? There is
Yeah,
no harm.
inevitably they will not respond to fluids.
I think there is no harm to give an extra bolus of hydrocortisone to anyone anyway. You can give the hydrocortisone, that should not be harmful if you think it is, it could be.
Yeah, yeah, of course. If there is a credible suspicion of insufficiency or Addisonian crisis. With the slightest suspicion, authentic suspicion of Addisonian crisis, you should give IV hydrocortisone, a bolus. Um, because and also patient profile matters a lot, Farag Bhai. If we are dealing with an 80 years old patient, you think more about sepsis, cardiac failure, and all those things. If you are managing an otherwise fit and well young person and they come with a circulatory collapse, you may see some evidences of they be febrile, their lactate may be high. So they generally respond to IV fluid, don't they? If they are not responding immediately, or their circulatory collapse is disproportionate to the degree of sepsis.
Mm.
So this is one thing for for insightful clinician. If you think it's an infection or circulatory failure, but you see disproportionate circulatory collapse or hemodynamic instability compared to what you expect in any infection or any other intercurrent illness, you actually start treating Addisonian crisis. And there could be other settings, like a fit and well person went for an elective surgery.
Mm.
They may have an undiagnosed Addison's disease or adrenal insufficiency. They may dip into crisis. So in scenarios like that, it's more straightforward than where it is precipitated by infection. A dental surgery, or a cesarean section, or a troublesome delivery, anything can actually precipitate. And if precipitate triggers are not infection and other precipitating factors, for example, trauma, surgery, delivery, all sorts of things, that is more obvious than infection.
No, thank you.
You suspect it quicker. The key is to
Suspension is the
suspect early.
key. Start treatment early.
Yeah,
And
high degree of clinical.
in UK setting, I also seen some of the paramedics in the ambulance. They
Yeah,
even start the steroid. They give the steroid in the
yeah,
ambulance
they do.
after suspicion,
Mm.
which is actually
They do, and that can be life-saving in
yeah,
many,
that is
in
sometimes
many
life saving.
many situations.
So I would say
Mm.
that's the key message for everyone today. Even with the slightest suspicion of Addisonian crisis, just to give the steroids and fluids, and then you investigate further.
Yeah.
These patients generally, after steroids and fluids, do they stabilize and go to medical ward, or do they need to come to HDU or ITU?
Um, in vast majority of cases, simply IV steroid and IV fluid fix the crisis. And unless they have an overwhelming other issue, for example, a very bad infection, very bad sepsis or organ failure, they actually manage to go to ward. Vast majority of Addisonian crisis that present to ED, they actually go to medical ward, particularly when it was suspected early and treated early. So early doses of steroid and fluid management helps.
Thank you. Um, I think we briefly covered the acute presentation of Addisonian crisis. Is there anything else the audience needs to know? And is there any alert bracelet or something? Have we discussed
Yeah,
about it? So
yeah, of course. There are a lot of other things that you have to remember if you're dealing with adrenal insufficiency. I wasn't saying those because I thought we should focus the emergency part of the journey of recovery from a person for a person in Addisonian crisis. So for the emergency department, my bottom line is Addisonian crisis can kill, and it kills by being forgotten.
hmm,
If you forget Addisonian crisis, it will kill you, kill your patient, and also can be distressing for the physician. And again, I am ample of hydrocortisone and a bag of normal saline. That's all make the call between life and death. when they recover the crisis and they get seen by an endocrinologist, that's a must. They should be seen by an endocrinologist
Mm.
to be investigated if it is a new diagnosis, or to be followed up if it is a known diagnosis. The strategic shift would be, now that you have treated crisis, you don't need any IV hydrocortisone anymore. You
Mm.
need to start them on replacement doses. So the physiological replacement dose would be 10 milligram by around 8 o'clock in the morning, 5 milligram at midday, 12 o'clock, and 5 milligram by late afternoon at around 4 o'clock. Hydrocortisone, if taken orally, the tablet has got half-life of around 4 hours.
Mm.
So you don't want to give hydrocortisone beyond 4 o'clock in the afternoon. If you do that, if you take a dose in the evening, that will keep the patient awake
Mm.
all night. So you want to retire in the evening. So you want to set them on oral replacement dose, but not to the ideal replacement dose then and there while they are still in hospital, still unwell. So you probably double the dose.
I
Give them 20, 10, and 10. And when they're absolutely fine, you can send them home with the standard replacement dose. When you send them home, you give them a steroid card that will mention the diagnosis, the steroid dose, and what to do in terms of crisis. So when they encounter to their next clinical point of care, everyone will know that this patient had a crisis. This patient is on that regime of steroid. And also, you give them an emergency kit, ideally, of hydrocortisone injection,
mm.
100 milligram, and that can be taken IM, because the patient will keep the kit with them, and whenever they feel in crisis, they can take it. Now, there's a lot of educations needed for all patients. You have to really explain to them when they should double the dose, and when they start thinking about taking the injections, and when they should run to any nearby A&E.
Mm.
So um, uh, there are a lot of education. We call it sick day rules.
Sick day rules.
I'm not going to the detail of sick day rules, but for the physicians who are listening, there is a website called Edison's Disease Self-Help Group.
Mm.
This is a very authentic website. They have been doing a lot of work around Addison's disease, and there are a lot of materials for both physicians and patients. And you'll be able to find answers, any questions related to management of Addison's disease or living with Addison's disease if you're a patient.
I think
Um, yeah,
no, I think thank you. I think you actually covered a very good, details on the, the management from switching from IV to oral and the time
yeah,
frame, and also the advice they take home with, and they must be seen by the endocrinologist. And I like the kit that in UK settings, I'm sure you're giving the kit for IM adrenaline,
yeah.
iron hydrocodone,
Hydrocortisone.
and some advice how to
Yeah.
manage. I think this is the very, very, very important uh, pack of information that
Yeah.
they go home with. Okay.
Sure.
Um, and how do you follow up these patients, or you don't follow up them?
Yeah, no, follow-up is absolutely paramount. Otherwise, they will come back to any with crisis. Follow-up, the objective of follow-up is to investigate them
Mm.
with endocrinologists to find out if it is an adrenal crisis, if it is a primary adrenal insufficiency, or secondary or tertiary, and what sort of steroid regime they should be on.
Mm.
Now, historically, everyone with adrenal insufficiency or deficiency, they will be on hydrocortisone 10-5-5. But there can be problems. Some patient, they actually don't feel best with hydrocortisone 3 doses every day. Some patients find it troublesome to take 3 tablets throughout the day. Someone has got a work pattern, they will find it incredibly difficult to take it, like somebody working in police or somebody working as a pilot. They may find people find taking tablets repeatedly throughout the day difficult for many reasons. And also, some people tolerate hydrocortisone. I have patients who don't tolerate hydrocortisone well. They get symptoms. So you then consider alternative. Alternative to 3 doses of hydrocortisone daily is single dose of prednisolone.
Hmm. I
And that need to be monitored very carefully to find the right dose.
I see.
So the ideal dose is kind of 3 to 4 milligram of prednisolone a day.
Hmm.
It can be tweaked to some extent, patient to patient, case by case. So you
Hmm.
need to follow up on them to see how they are managing with the replacement dose, number one. Number two, of course, they need to be investigated by the endocrinologist to find out what's going on, if it is pituitary, hypothalamus, or adrenal. And also, if they are primary adrenal insufficiency, many a times, more often in young people than the elderly, you will find association of other autoimmune disease. For example, type 1 diabetes, autoimmune thyroiditis, pernicious anemia,
Hmm.
skin problem like vitiligo. So autoimmune polyendocrine syndrome need to be screened as well. So that's why they need follow-up.
Thank you so much. Thank you so much. So I think we have covered briefly about the overview and acute or emergency management of Addisonian crisis. On that note, I would like to move on to the next topic. Is there anything else you would like to mention here, or
No, closing line, um, high degree of suspicion, ample of hydrocortisone, and fluid balance that saves life.
thank you so much, Dr. Said. Thank you so much, and I'm sure the audience also listening that the what should be the emergency management and how much aggressive we need to be to save this life. And these are the patients you don't want to miss out later on.
Absolutely, yeah.
Right. So moving on to different topics, we would like to, I would prefer you to give us some highlights on pituitary apoplexy. This is, I don't think it's a very common I have seen in ED, but again, it can be. Can you give us what of
Yeah.
the presentation that should made us suspicious
Okay.
of pituitary apoplexy? Yeah.
Right. So, pituitary apoplexy is, by definition, it is actually a hemorrhage or infection of the pituitary gland. Now, in vast majority of cases, it will be in the background of a macroadenoma. If someone have a macroadenoma diagnosed or undiagnosed, they are at risk of having a sudden hemorrhage or infection. Now, without macroedema, people can have pituitary apoplexy. It's just more frequent in the background of a large tumor. And if you imagine, if pituitary, the sala is a very small area, isn't it? And you have a pea-sized pituitary gland there. And if you have a tumor there, and that's bleeding inside, so it needs volume to accommodate the bleeding, right? So the volume expand. And when volume expand, it's actually very close to optic chiasm.
Hmm.
So inside the skull, intracranial, if for any reason you need extra volume, it causes headache.
Hmm.
And because it is for a sudden incident, hemorrhage or infarction, you will feel sudden headache, sudden severe thunderclap headache. It's a very strong differential for subarachnoid hemorrhage.
Hmm.
Very often you see people with subarachnoid hemorrhage in ED, don't you?
Yes.
And you actually focus on sudden severe thunderclap headache, the worst headache of their life. Every patient will say that.
Hmm.
And if that comes with two other features, because Sala is very close to Peter, is very close to optic chiasm, then it will cause some visual problem, ophthalmoplegia, double vision. So you check for ask for double vision, check for diplopia and ophthalmoplegia by concentration. And if you see one of the ocular nerves are paralyzed, then pituitary apoplexy is a real player in the scenario. Um, and the third is, if pituitary is bleeding, it will not make any hormones. It's a master gland. It makes a lot of hormone. It will not make any hormones. So the triad of sudden severe headache, visual problem, and pituitary hormonal insufficiency. This is how a pituitary apoplexy present. The present dramatically. The present with hyperacute onset of symptoms. Now you understand headache and visual problem that easily detectable. But hormonal insufficiency, pituitary insufficiency, how you detect that? Again, cortisol comes in play because growth hormone, reproductive hormones, if the gonadotrophins are not coming, growth hormone are not coming, you will not feel anything very immediately.
Right.
Thyroid not coming, the impact will not be immediate. Impact will be immediate if ACTH is compromised and you are not making enough cortisol. So again, hemodynamic compromise, very important. So you need to, if you see someone with hemodynamic compromise complaining of headache, visual problem, pituitary apoplexy is a real differential. And you should, of course, think about other differentials like seborrheic hemorrhage, meningitis, stroke, all sorts of things. But pituitary apoplexy here is the top differential.
Thank you so much. I think it's a very, very interesting topic to here to discuss again. And most of us in ED, we think of, oh, sudden severe headache, it must be subarachnoid hemorrhage.
Mhm.
However, it tell us that triad, this is not to miss, to be honest with you. Along with this headache, if there is a cranial nerve deficiency, double visions,
Yeah,
and at the same time we suspect acute suppression of all the hormones, pituitary hormones,
yeah.
like an Addisonian crisis, then the suspicion is it could be a pituitary
Yeah.
apoplexy. Oh.
And biochemical finding can be really important here because you see there's cortisol deficiency.
Mm.
So you'll have hyponatremia, hypoglycemia, hypotension. So you treat all those. And then what happens? Pituitary apoplexy can also cause posterior pituitary dysfunction.
Mm.
And you don't make any ADH. So you start losing all the water.
Right.
So if patients complaining of polyuria, or if you are treating a very unwell patient and you are measuring intake and output, you are monitoring urine output, and you see that they are making a lot of urine, precisely, you will not keep them in ED for 24 hours.
No.
So
Yeah.
counting for 3 liters over 24 hours can be, misguiding. So
Mm.
you look for hourly urine output. If you see someone is making more than 300 mils of urine
Mm.
um, in consecutive hours, then you definitely start thinking about ABP deficiency, which previously was called used to be called diabetes insipidus. We don't say that anymore. We say AVP deficiency. So when AVP deficiency comes in play, you then start having polyuria and hypernatremia. So you
Mm.
may think of, you may see very high sodium who present a bit late in the course. You may see high sodium, and you may think, oh, if you do a cortisol deficiency, it should have been hyponatremia.
Yeah.
So you can be tricked. So this is a trap.
Yeah.
So you have to remember the triphasic sodium water electrolyte responses to AVP deficiency. So that should be kept in mind as well while you were dealing with biochemistry of a suspected pituitary apoplexy.
So this is very interesting. Thank you. So we cannot actually rely on the sodium, low sodium, or even, as you said, with AVP deficiency, it can be high sodium.
We- Yeah, exactly. We can't rely on just a single measure of electrolytes. We have to check them repeatedly.
Repeatedly,
We
yeah.
have to see the trajectory, the
Mm.
trend, which is important. At very hyperacute presentation, a pituitary apoplexy can present with hyponatremia because of loss of cortisol production. However, as it progresses, it can also present with hyponatremia because at that point, ABP deficiency will come in play.
And I think
But
that,
of course, in any case, hypotension, hypoglycemia, and a typical presentation would matter. Sorry,
yeah. And I like the idea that you said if someone is producing more than 300 mils of urine per hour in ED, in that we have to suspect
consecutive hours.
consecutive
In
hours.
consecutive hours, that's a red flag.
That's a
So
red flag. How
people
do,
presenting with hypotension and making this much urine,
Hmm.
it's a very red flag.
So on the first go, what are the investigations should we order from ED?
I think every emergency physician would request a CT head for this patient,
Hmm.
and I think which absolutely justified. Although CT head will not give you a diagnosis of pituitary apoplexy confidently or pituitary hemorrhage. You need an MRI, but you don't jump into an MRI if someone presents to ED with headache. You go for a CT head to rule out bleed,
Hmm.
with say ruling out differential like subarachnoid hemorrhage. And if you see someone, you did a CT and there's no bleed, but still having hyperacute headache, circulatory compromise, suggestive biochemical abnormalities, so your suspicion get kind of firmer. So you need biochemistry using is, and you need full pituitary function assay. So
Okay.
when you do that in pituitary function assay, you may see because IGF-1 takes time. You don't get results in hours. It
Hmm.
takes days, and you will get TSH, cortisol,
Hmm.
LH, FSH, testosterone, all this very fairly quickly. So you may see pan or partly
Hmm.
hypopituitary state. Um, yeah, so pituitary hormone assays, organ functions, by fluid and electrolytes balances. These are all important if you are investigating. And an MRI as quickly as you can, ideally within 24 hours of presentation.
Thank you. And moving forward, how do we manage these patients in ED?
Excellent, excellent question, Faragway. You need a multidisciplinary. The moment you suspect pituitary apoplexy, you actually you should be on your phone
Hmm.
calling neurosurgeons, endocrinologists, and ITU. So it needs a very multidisciplinary management. Um, while you are managing their, you are stabilizing them from a hemodynamic point of view. We're also asking them if they have any visual problem, if the headache is intractable and not responding to any analgesia, because this visual problem is actually indication for quick neurosurgical intervention.
Hmm.
So if they have progressive ophthalmoplegia
Hmm.
or if their vision is compromised or intractable headache, and you do neuroimaging and see it's compressing optic chiasma
Yeah, yeah.
um, or optic trap, so you need urgent decompression. So that's the urgent bit. uh, if they are not having compressive symptom, it's manageable conservatively. So
Hmm.
you actually manage the hormonal deficiencies, largely adrenal insufficiency,
Hmm.
thyroid replacement. Never replace thyroid without replacing steroid, as we all
Oh.
know. Yeah, yeah. And going forward, managing their reproductive axis as well. They may need some testosterone replacement if it becomes chronic, take time. But ideally, acute management, of course, fluid and electrolyte balances, replacing the hormones, and then rechecking all the pituitary functions in 6 weeks' time, because sometimes they recover and you may not need a pituitary hormone replacement for indefinite periods. Some people recover um, in terms of pituitary function, and If there are definite indications for surgery, yes, of course, neurosurgeons get involved. But in many cases, it can be managed conservatively.
Thank you. And you did mention that never replace thyroid before you replace the cortisol
Yeah.
steroids. Why is that? And can you tell us for the audience what happens?
So hydrocortisone is a permissive hormone for thyroxine to work.
Hmm.
What thyroxine does, thyroid actually facilitate our metabolism
Yeah.
in the whole body. For all the cells, cellular metabolism, you need thyroxine. And by facilitating metabolism, by augmenting metabolism with giving more thyroxine, um, or replacing the optimum thyroxine, you are actually precipitating the cortisol deficiency if there is any. So they will require more cortisol when levothyroxine is in the field than not. So you will simply precipitate an Addisonian crisis.
I see. No, thank you for this information. So you said it is a multidisciplinary approach. So as soon as we suspect, pituitary apoplexy, we need to be managing
Yeah.
the patient at the same time. I should be on the phone, calling
Yes.
neurosurgeons, endocrine, ITU, all these people.
Yeah.
How common are these scenarios in your practice or in ED? How often should we expect these scenarios? Are they common?
Pituitary apoplexy is rare, thankfully.
Hmm.
It's not very common. But the problem with the rare presentation, when present, it tend to get missed
Hmm.
because it is rare and people don't often think about it. So I think the classic triad is there: headache, visual problem, and hormonal insufficiency. But I think if someone with headache presenting with hemodynamic instability, of course you would think meningitis, meningoencephalitis, and
Yeah.
also, of course you would think seborrheic hemorrhage and everything. But you should also think about pituitary apoplexy, particularly if they have suggestive background. If someone presenting with someone with a known macroadenoma, pituitary macroadenoma, presenting in a similar fashion, this is your
Right.
to-go differential. If circumstances are suggestive, for example, a big hemorrhage
Hmm.
during delivery or in any other circumstances, a big hemorrhage can potentiate a pituitary infarction, pituitary hemorrhage. So this sort of thing should actually be a whistleblower.
Right. So the potentially, even if it's a big hemorrhage and having, ophthalmoplegia,
Yeah.
likely that the patient needs a neurosurgical intervention, go to ITU and theaters uh,
Yes.
down the line.
But that's a neurosurgical decision that they. This is why you need to bring them
On
in the
board.
scenario sooner rather than later.
Um, if there is no ophthalmoplegia, is it still a possibility that it could be apoplexy?
Yeah, yeah. So they don't tend to present with classic triad all the time.
Okay.
So if you imagine why they're having ophthalmoplegia, it would be depend on the extent of bleeding and the extent of volume expansion. If it is getting big enough to compress optic chiasm, or the other optic nerve and tract. If it is not, then they will not be causing ophthalmoplegia, but they will still be presenting with hemorrhage. They will still be presenting with pituitary hormone suppression. Sometimes they may not. There can be small hemorrhage causing headache, may not suppressed hormone. You do all the pituitary hormone assays and everything is fine, but then you do an MRI and see
Right.
a pituitary hemorrhage. So this we're talking about classic presentation,
Yeah.
but there can be so many,
Variations. Variation.
variations in presentation.
And I think it is said that MRI is the key gold standard in diagnosis.
MRI is the gold standard for picking up pituitary abnormalities. You do MRI pituitary
Hmm.
um, to get the diagnosis. But if MRI is contraindicated or not available, you can, of course, do CT. They can be helpful to some extent.
Hmm. Thank you so much. Um, just for the audience and everyone, I think we are nearly there. Today we just covered uh, again two
I
topics.
think you're freezed.
Okay, so thanks again. I think we are nearly there. We have roughly 7 minutes to
Mhm.
11. And I think we briefly covered Addisonian crisis and pituitary apoplexy, which are really, really endocrine emergencies. Um,
Mhm.
but the pituitary apoplexy is not as common as Addisonian crisis. But again, as
Mhm.
as you said, it can be missed because if something is not common, we probably don't think it is a differential. However, we know the triad. We know that, we can still treat, and as long as we suspect apoplexy based on the symptoms, we can actually involve neurosurgeon early on, ITU and endocrinologist. um, just to summarize at the end, so these patients, in terms of follow-up and can they go home, and what happens at the end?
Okay. So the need endocrine follow-up long term, and the objective of follow-up is to see whether the pituitary function recovering or not.
Mm,
Number one. Number two, what was the actual pathology in the pituitary gland? If it is a big macroadenoma, there will be a risk of having another um, episode of apoplexy. So neuro neurosurgeons and endocrine then sit in the MDT and decide what would be the definitive treatment.
mm,
If the tumor, what's the nature of the macroadenoma? It could be anything, prolactinoma, acromegaly. So pituitary function assay will give an answer about the character of the tumor, if there is any. So MDT will decide the long-term management plan. Endocrine will follow up for the hormonal assessment intermittently, and repeated follow-up will actually help finding the correct dose of replacement if needed. If it is not macroadenoma, any other pituitary pathology, but then again, the MDT or endocrine can decide. It will not touch emergency physicians again.
thank you. Thank you. Is we're nearly there. I don't think we should be able to cover the other topics today, Dr. Said again. Uh,
No problem.
thanks so much for covering.
Yeah, looks like
Yeah, thanks so much
there's
for.
a lot of interlink between endocrine emergencies, and so when we start talking,
Yeah.
there's a lot to cover actually.
And obviously, I mean, even though we try to focus on ED point of view, there is still a lot to talk about. And I believe this is really helpful. And we should not be rushing just to cover the topic, but we should be actually focusing on the ED management and try not to miss this diagnosis when they present in front door or any hospital anywhere. In Bangladesh context, they
Yeah,
can be anywhere. In a UK context,
yeah,
yeah,
definitely.
they come through the ED, but
Mm.
in in Bangladesh context, these patients can be anywhere presenting first. You know, it could be in medicine or medicine even in the clinics. Sometimes they go in the clinics and go and ask maybe a different specialty. Anyway, um, in summary, any last words from these two topics for the audience?
So these two topics are quite interlinked, aren't they? Because Addisonian crisis, they present with typical features, and when it is pituitary apoplexy, um, in addition to headache and visual problem, which is compression, um, you know, compression features, the systemic features can mimic Addison's actually. So literally, we talked about primary and secondary adrenal insufficiency in a critical care setting. High degree of suspicion absolutely important. The actual uh, features of a recent crisis can be masked by its trigger. So here you really need to carefully think about all these things. And fluid balance, monitoring and management of electrolytes at the critical stage, absolutely important. Um, don't overkill with steroid because if someone presenting with the frank sepsis, you don't want to burden them with more steroid, but also be very careful of not missing the need for a steroid because this can really make a difference.
Thank you, Said. Thank you again. It was very informative, very useful. I think audience should be able to see the recordings and ask any further questions. And hopefully we will see you next because I think there are other topics to cover with you as well.
Yeah,
Dr.
absolutely.
Thank you so much. And today, I think we should conclude this meeting. And again, audience, if you have any questions, you know my email and the Facebook ER Skill Lab. So just ask other questions, and then we'll come back to you with new topics next time. Thank you, Dr. Said. Thank you all.